بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. معكم دكتور ياسر طاقة. I am going to talk today about one of the important lectures in basic neurosurgical practice, which is the subject about I'm going to talk about intracranial infections in neurosurgical practice. You know very well that infections of the CNS is part of any infection in the body and can affect the CNS as it can affect any part of the body like the GIT or any other, or chest, for example, the lung or any other parts of the body. And in fact, many infections of the central nervous system are to be treated only with medical treatment, not surgical treatment. But we have some aspects at which there may be a need for a neurosurgical intervention to treat these infections. So that today lecture, I'm going to talk about the three important subjects of neurosurgical nervous central nervous system infections which are related to neurosurgery. For example, for number one, I'm going to talk to you about bacterial meningitis, and you know very well that bacterial meningitis is to be treated by medical treatment only. But now also you will see that sometimes there may be a need for some neurosurgical intervention to treat the complications of these infections. Also, one of the unique and important subject in neurosurgery is about brain abscess inside the brain, abscess inside the brain, and the neurosurgical emergency of subdural empyema, as you are going to see in the last part of this lecture, inshallah. So that I'm going to start with uh, bacterial meningitis. In fact, bacterial meningitis seldom requires neurosurgical interventions. What about the progress of meningitis, which are sometimes maybe in need for neurosurgical interventions? For example, meningeal inflammation. The sequelae of meningitis will be having meningeal inflammation, subpial encephalopathy, cortical venous thrombosis, or cerebral edema, and sometimes may even end by death. Now, how we can diagnose case of bacterial meningitis, you know, by obtaining CSF sample via lumbar puncture, of course, after being sure that there is no papilledema, and then CT brain to exclude the complications, which you see just in a few minutes. Now, treatment of bacterial meningitis, you know very well they are to be treated by proper antibiotic, broad spectrum antibiotics for long time, not short time. I don't mean months, but I mean many days. Now, what are the complications of bacterial meningitis, which are sometimes in need for some neurosurgical interventions? Number one, cerebral edema. And you know, I taught you about cerebral edema with its manifestation and treatment. Also, seizures sometimes can represent as a complication of meningitis. Hydrocephalus. And in fact, we taught you about hydrocephalus, and we told you that the complication of bacterial meningitis when we got post-meningitic hydrocephalus, it will be a type of communicating type of hydrocephalus, not obstructive, and due to scarring of the auricular villi, the site of absorption of CSF at the end of CSF circulation. Subdural effusion, sometimes may be in need for aspiration of this effusion, or subdural empyema, which I told you that's one of the neurosurgical emergencies. A brain abscess as a complication of meningitis, and we'll go in just 1 minute to the details of this important disease. And lastly, ventriculitis, infection of the ventricles, I mean CSF inside the ventricles, and maybe in need for sometimes some neurosurgical intervention. For example, we may put external drain to the infected ventricle, of course, in addition, of course, in addition to the proper or broad spectrum antibiotic. Now, you can see in this figure, for example, bacterial meningitis with cerebral edema, edematous brain, congested brain, unhealthy brain, as you can see. Also, hypodensity surrounding the whole brain in CT scan, indicating the presence of cerebral edema as a complication of bacterial meningitis. This is MRI of the brain showing also a complication of meningitis with cerebral edema, and also other cases of MRI with also cerebral edema as a complication of bacterial meningitis. In fact, I will not go to the details of the treatment of brain edema because we told about it in details in the previous lectures. Bacterial meningitis with suppuration can sometimes be seen, as you can see here. Is this a pus over the whole brain is covered? Of course, this is just a post-mortem specimen of a brain. Now we are going to the next important subjects, which is important for you as a general practitioner, as a doctor, and important in the exam, important in your daily life as doctor, which is the subject of brain abscess. In order to summarize the whole subject in few words about the brain abscess to start with it will behave just like brain tumor, a space occupying lesion. And this space occupying lesion may be found anywhere in the brain, for example, frontal lobe or parietal, temporal, occipital, cerebellar, or even sometimes related to the brain stem as well. And this brain abscess will represent just like tumors. I mean, maybe asymptomatic, maybe physical intracranial pressure, or may cause, for example, a compression of the fourth ventricle and resulting in, for example, hydrocephalus. I mean, just like any brain tumor. Now, what are we going to think of? So that the presentation of this patient may be just like the presentation of patients having brain tumors, as we just taught you in the last lecture about brain tumors. So that many features will be just the same as brain tumors, but we are thinking of one important thing of any abscess in the body. You know, all of you, that any abscess in the body will the patient will be toxic. There will be high fever. There will be a site of swelling and tenderness, etc. I mean, fever is mandatory for any abscess in the body, and the toxic patient, I mean, general features of infection will be quite apparent in any abscess in the body. Imagine, for example, a woman having a breast abscess, how she will be. She will be toxic, she will have fevers, and so on. Oppositely here, in case of brain abscess, you'll see that these patients, yes, they are having features of increased cranial pressure, number one, and a feature of space occupying lesion, and focal deficits sometimes. But as we are going to think about the general feature of infection, you will be surprised that most of these patients having no toxic patient, no general presentation of the usual abscess in the body. And if they are found, they will be mild, as you are going to see later on. So that, what about the etiology and source of infection in brain abscess? We have three sources of brain abscess formation, either hematogenous separate, direct separate, or post-traumatic. Regarding hematogenous separate, through the blood, from septic site or occult focus, for example, from dental infection, respiratory tract infection, or endocarditis, usually cause multiple brain abscess because this there will be showering of the focus of infection, I mean the nodules of infection, for example, or bacteria throughout the brain, and they will result in multiple brain abscesses. This route is commoner in patients having congenital heart disease with right to left shunt. You know that the right side of the heart containing the unclear blood, not deoxygenated blood, while the left side of the heart is having the oxygenated blood. Here, what will be mixing of the drained blood from the body? I mean the deoxygenated blood with the oxygenated blood, and then the bacteria will go from the right to the left and then to be pumped through the left ventricle to the brain and to be distributed and resulting in multiple brain abscess. Direct separate from an adjacent infected paranasal, for example, paranasal sinus, middle ear, or mastoid infections. Or post-traumatic direct inoculation from trauma or after surgery, I mean, for example, surgery for brain tumor or any other surgery. And put in your mind that in 25% of patients, no cause can be identified as a cause, I mean, as a source for this brain abscess. And this is not a small number. 25%, I mean, one quarter of the patient, you will see no primary source for the brain abscess. As you can see, for example, in this diagram, I'm going to show you, for example, this is the bloodstream and going to result in multiple brain abscess, or from mastoid infection to get local abscess of the brain, or from paranasal sinus to the also frontal lobe, for example, from frontal air sinus to the frontal lobe, resulting in focal abscess, local abscess at here from direct spread, or as I told you, post-traumatic. Now, if I suppose to you that this diagram is showing to you the brain and multiple brain abscess, you are going to think of hematogenous separate, hematogenous abscess, and in case of right to left shunt patient congenital anomalies. While this diagram shows you how from supurative otitis media will go to result in temporal loop abscess of the brain abscess at the site of the temporal loop. And this diagram shows, for example, after fracture skull, a fracture skull at this site may result mainly if it is a compound skull fracture, and there will be connection between the brain and the outside, and may result in brain abscess. That's why we told you that when we're going to deal with the breast skull fractures, if they are closed, we have mentioned to you some indications for surgeries. The indications for surgeries which are not usual, not always done. While when we talked about compound skull fractures, you said that treatment of compound skull fractures are usually or always by surgery. In fact, we have some patients who are having high risk for brain abscess formation, and these include the following patients: cyanotic heart disease, and these will be having right to left shunt, as I told you. Immunocompromised patients because they have low immunity and vulnerable to abscess formation. Diabetic patients also have low immunity. Solid organ transplant. Why? Because after, for example, transplantation, in order that the body will not reject this organ, we are going to give the patient anti-immune drugs in order to decrease the immunity, not to let the immunological system of the body to be sensitized and react against the kidney, for example, to reject it. Hematological malignancy, because also can lead to formation of brain abscess, and long-term steroids, they result in decreased immunity on their long-time used. What about pathology of brain abscess? A brain abscess formation, in fact, it will pass into 4 stages. The first stage called early cerebritis. From its name, cerebritis, I mean infection of the cerebral cortex, for example. Early cerebritis. This will be in the first early 1 to 3 days with inflammatory cells only. I mean, for regarding histopathology of this patient, you are going to see that there is only inflammatory cells. Late cerebritis extended from day 4 to day 9 with formation of necrotic core and increasing number of macrophages and fibroblasts. As you are going to see, that this necrotic core will be changed later on to the cavity of the abscess. Then early capsule formation, days from 10 to 13 days, and late capsule formation, the mature capsule by day 14. So that early cerebritis, late cerebritis, early capsule formation, late capsule formation, or mature capsule. Now, the formation of the collagen capsule in developing abscess is the single most important responsible that limits the spread of infection to the rest of the brain. And in fact, this is number one, it is a protective to the brain tissue. So that once the brain abscess is present, there will be limitation of this abscess not to be separate to the whole brain by this strong collagen capsule. Number two, that this may be the cause why these patients are having no symptomatic features like toxicity or high fever, because it is just limited inside the collagen capsule. And may also give me clue later on. If, for example, if I do, for example, lumbar puncture, in fact, it's contraindicated in this patient because they are having specific pain. But if I do lumbar puncture for this patient, I will get for mostly negative for infection of the CSF. This is, for example, collagen capsule. As you can see, this is a post-mortem specimen with the brain abscess located in this, we don't know right or left side, according to this, whether this anterior or posterior. Whatever, this is the collagen capsule. As you can see it very well, this is the abscess cavity. And I return back, you can see that this is thick capsule that will prevent the spread infection to the whole brain. Also, this is the collagen capsule of a smaller brain abscess. Now, from the pathology, I'm going to jump to the most important part of talking about brain abscess, and it is the clinical features, because you must have good idea about this, and they have high possibility of thinking of this person may be having brain abscess, high degree of suspicion. And as I told you at the start of talking about brain abscess, I told you that they will be having fears of specific brain lesions, just like brain tumors. But we are thinking of systemic fear of infection. We will see that they are low. Features of raised internal pressure, and I will not repeat them because you know them very well, like headache, nausea, vomiting, seizures, meningeal irritation may be present. Focal neurological sign also because they are specific brain regions. For example, the frontal patient complaint, for example, right frontal brain result in left hemiparesis or hemiplegia. Regarding systemic features of infection, like fever, is present in half of these cases, and usually they are of low grade, so that we don't suspect that these patients will have, for example, the degree of 39 or 40 degrees. No, we will, for example, may got, for example, 38 or, for example, 37.8. Now, what are the investigations or reported investigations to diagnose brain abscess in suspected patients? You know the investigation, radiological investigation, which I'm also taught to you regarding CT and MRI, but here, strangely, we have laboratory investigations, and these laboratory investigations include the following: the white blood cell count, white BC count, and erythrocyte sedimentation rate, I mean ASR, are usually elevated. Measurement of C-reactive protein is useful in differentiating brain abscess from a tumor, as it is elevated in case of abscess but not in case of a tumor. Lumbar puncture is contraindicated in case of brain abscess to avoid fatal brain herniation. And as I told you, the findings of CSF examination are non-specific in case of brain abscess. I don't think that you will find, for example, the pus cells or other infection cells in the CSF of the patient. Regarding radiological investigations, as you know, the CT and MRI are the investigation of choice in the diagnosis of brain abscess. They see the brain performed with and without contrast, and also MRI done with gadolinium enhancement. They will show both of them, CT and MRI, single or multiple space occupying lesions that's well delineated with an enhancing wall. What do you mean by the enhancing wall? It is the collagen capsule with variable surrounding edema surrounding the brain abscess. For example, you can see this is CT scan of a brain showing there will be there's you can see in these two sections. In fact, this is without contrast, I mean native. You can see that there's hypodensity at here, the same hypodensity at here in the left parietal lobe. Now, after giving contrast, what will happen? You are going to see that in fact the pathology was not this hypodensity, but it is this pathology. This is the collagen capsule ring enhancing lesion. This is typical for brain abscess. This is a regular thick wall, oval or rounded, and surrounded by perifocal edema. I'll go back again to the first one. This is native, and you can see in fact this is the lesion, I mean the abscess, and this is surrounding edema. Also, this is the lesion, I mean the abscess and surrounding edema. And after contrast, you will see the contrast enhancement, I mean ring enhancement, just like this, before and after contrast. So that very clear. The site and size and shape of the abscess is quite clear by CT of the brain. This is MRI of the brain also, and you can see the ring enhancing lesion surrounded by perifocal edema also in the left parietal lobe of the brain. The differential diagnosis of a single brain abscess on CT and MRI include the following. Number one, solitary metastasis, primary brain tumor, or sometimes cerebral infarction. While the differential diagnosis of multiple brain abscess is from multiple metastases and tuberculoma. What about the treatment of brain abscess? A brain abscess treatment, in fact, as far as there is infection, we are thinking of medical treatment. For example, in the early cerebritis, late cerebritis, before the formation of collagen capsule and the cavity of the abscess is filled with pus, we can start and manage this patient with medical treatment. And now we are going to see that we have two lines: the medical treatment and surgical treatment for brain abscess. Now, Regarding non-surgical and medical treatment, this is indicated if an abscess is an abscess that is less than 2.5 centimeter, 200 centimeter in diameter. I mean small abscess. Or as I told you also before the formation of collagen capsule, I mean cerebrites, if I was able to diagnose them. But as far as the brain abscess is settled and having the collagen capsule, so if the diameter is less than 2.5 centimeter, then we can start biomedical treatment. This including antibiotics. Appropriate antibiotics selection is based on culture and sensitivity result. Example, penicillin G, trimethoprim, sulfamethoxazole, and aminoglycosides. Appropriate antibiotics should be used intravenously for at least 6 weeks. 6 weeks, not less than 6 weeks. Corticosteroids help to reduce cerebral edema around these lesions and thus reducing the intracranial pressure. But in fact, they have bad effects because they can inhibit formation of the abscess capsule, I mean the collagen capsule of the abscess. So that use of corticosteroids in case of brain abscess, we will make balance. If there is a huge, for example, edema and signs of severe intracranial hypertension, then we can use corticosteroid even for a short time until the intracranial pressure decreased, because we want to avoid the bad effects of corticosteroid by reducing by inhibiting formation of collagen capsule. Anticonvulsant therapy is routinely started as epilepsy frequently complicates brain abscess cases. These are regard to the medical treatment. Regarding surgical treatment of brain abscess, in fact, we have two methods to treat brain abscess surgically. The first method is by aspiration. The second method is by excision of the abscess. In fact, aspiration of the abscess is done by using what's called a brain cannula with a stereotaxy or without stereotaxis through a ball hole. Indications for aspiration include the following cases. If we are having multiple abscesses, for example, these multiple abscesses are distributed on the surface of the brain or in many areas of the brain, for example, more than 2 or 3 abscesses. If I'm going to try to do excision of these abscesses, what I'm going to do, I'm going to do multiple craniotomies for example, right side and left side, and this is quite difficult and dangerous, so that we are just doing aspiration, from example, from right or left side by just burr hole. Deeply seated abscess, because if you want to do excision of this abscess, in order to reach this deeply seated abscess, I want to do incision of the cortex of the brain to go deeply inside and to reach this deeply seated abscess, and this will result in more and more damage to the brain tissue and focus deficit postoperatively. Critical location number 3, like for example, abscess near the motor area or speech area, because manipulation at that site may result also in focus deficit. Poor general condition of the patient, because this patient, for example, old age patient, diabetic patient, which are liable to get this brain abscess, they may not be able to withstand long surgery for craniotomy, so that shorter surgery by doing aspiration through a bar hole is better for these cases. You can see, for example, this is stereotactic aspiration of brain abscess. As you can see, we are introducing this through the brain cavity through a ball hole and to reach the proper site of the abscess and drain it. Also, another case of stereotactic abscess aspiration. You can see by stereotactic aspiration of brain abscess, we will have measures to localize this exact site. We can see, for example, this is deep seated abscess. If I want to excise this abscess, I want to do craniotomy at here. Then I do incision of the brain tissue deep until I reach this area. And this is quite dangerous because I do injury to this whole area. So that we are just enough to do aspiration of the brain abscess by the brain cannula through a ball hole. Now, this is, for example, also multiple abscess as indications for brain abscess aspiration, not by excision. Number 1, number 2. In fact, they are not the 2 only; they are 3. You can see after contrast 1, 2, 3 abscess at here. This is without contrast, and this is after contrast 1, 2. The third one is just at here. after contrast is very clear. So that how to I'm going to do excision of these multiple abscesses difficult. So I may do only aspiration even of this large one, maybe so enough. This is, for example, deep seated abscess, not near the surface, also indicated for aspiration. And as I told you, for a critical location or poor general condition of the patient. Now, aspiration or drainage is followed by intravenous antibiotics for at least 6 weeks, so that aspiration or drainage is not enough alone. It must be followed by intravenous antibiotic for at least 6 weeks to complete eradication of the abscess. Because you can imagine that when I'm going to introduce the needle, I return back just a few slides. You can see, for example, this slide. Okay, if I introduce the brain cannula inside this cavity and then do aspiration through a syringe and through a small hole by syringe, can I guarantee removal of the whole pus from this cavity? Never, never, never. So that we will get the benefit of aspiration. That, in fact, in case of excision, I will remove the whole abscess and definitely removal, also followed by antibiotic. But regarding aspiration, I'm sure 100% that I will not be able to remove the whole pus from this cavity. So what is the benefit of aspiration? Number one, I will do decompression, I mean decrease the intracranial pressure. Number two, I am going to get a sample of big sample of pus, essentially for culture sensitivity to see what is the proper antibiotic to be given to this patient for, as I mentioned, at least 6 weeks after aspiration of the abscess. Surgical treatment also, the second line of surgical treatment is by excision of the abscess through a craniotomy. The first one, as I told you, aspiration via burr only burr. While cases of excision of the abscess are in need for craniotomy, just like we are going to remove brain tumor. These include the indications for excision of abscess include the following. Number one, multilocular abscess, as sometimes difficult to aspirate all the loculi, so that we will do the excision of the whole abscess. And in fact, multilocular abscess is not multiple abscess. This one, for example, this one is multiple abscess, while the multilocular abscess, you are going to see that the abscess cavity, the whole cavity is divided into two by just like a wall. Superficial abscess also indicated for excision. Why? Because it is easily accessible abscess and can be removed easily. The presence of foreign body mandatory for this case to do excision of the abscess, because the cause of this brain abscess is the presence of the foreign body. So that if I will not remove the foreign body, just do aspiration of the pus, then the foreign body is still present and the source of pus is still present and there will be recurrence of the abscess. So that I must do removal of the abscess, I mean the whole abscess, and also removal of the foreign body also at the same time. I mean excision of the abscess and removal of the foreign body. Fungal abscess. And why fungal abscess? Because they are known to have poor response to antifungal therapy. May be not able to cross the blood-brain barrier easily, and no response of this patient to antifungal therapy. Cerebellar abscess, because, for example, called posterior fossa abscess, because failure of treatment of lesions at this location can lead to rapid deterioration and death. And why this rapid deterioration and death? Because they will result in obstruction of the fourth ventricle and resulting in sudden, severe, acute hydrocephalus, which may result in obstructive hydrocephalus due to obstruction of the fourth ventricle by compression from the cerebellum, or sometimes even when may got intraventricular abscess inside the fourth ventricle. Anyway, there will be acute hydrocephalus may result in herniation of the brain and death of the patient. Abscess containing air also they must be treated by surgical excision, not by aspiration. And air from where to come to this abscess? It will become from, for example, nearby paranasal air sinuses, or from sometimes from mastoid air cells. And they will still recurrent if abscess if I not do excision of these abscess. Abscess associated with CSF leak Here, why? Because excision of the abscess and should be done with repair of CSF leak is mandatory to these patients. And lastly, we do excision of the abscess if the abscess which failed to resolve after aspiration of the abscess through the burr hole. So this in summary, as I told you, the most important indications for surgery. So that if I ask you, the presentation of brain abscess in general will be by just like spatial biochemical region, increased pressure, all increased pressure and focal deficit, and the systemic features will be either absent or low, and a treatment will be lying into either medical or surgical treatment, and surgical into two lines, either by barrel aspiration or by excision of the abscess via craniotomy. You can see, for example, this is a case of multilocular abscess. This is the abscess cavity, the wall, external wall, and there is septum inside. If I do aspiration from this through the burr hole, I will be able to aspirate only one part, either this one or this one. The other one will still, so that still contain the part, so that I do excision of the whole abscess better than to do aspiration. This abscess is quite near the surface, so it's accessible and can remove it through craniotomy better than to do just aspiration of the abscess. This is foreign body caused abscess. This is the shell, for example, shell, and this is the abscess just nearby it. These are the radiations. The artifact happened in the CT after presence of shells, and you can see that the cause of this brain abscess is this shell. If I not remove this shell, for example, just to aspiration, yes, there will be a patient will get better for a few days. Then he will get recurrent abscess formation and recollection, so that we must remove the abscess as a whole by craniotomy, and we must also remove the cause of the sepsis, I mean the shell from this patient. Cerebellar abscess, for example, you can see this is cerebellar abscess compressed on the fourth ventricle and may result in hydrocephalus. Or sometimes this abscess is inside the cerebellum, inside the fourth ventricle and causing also obstruction of the fourth ventricle and may result in acute hydrocephalus, obstructive hydrocephalus. The last part of this lecture, I'm going to talk to you about one of the neurosurgical emergencies, and that is subdural empyema, which is the last topic about neurosurgical aspects of infection of the CNS. And subdural empyema, in fact, the source of infection here, although in fact it is uncommon, but may develop following sinusitis or mastoiditis. And it is dangerous and carry high risk of mortality, may be reaching up to 5 to 10% of patients will die. Pus is collected in case of subdural empyema over the cerebral convexity or in the parafalcine space. You can imagine now pus over the cerebral convexity, how much will be the irritation of the brain, how much will be the pain and the toxicity of these patients. You can imagine them. The clinical presentation of these patients is differ completely from patients having brain abscess. Here there will be frank feature of infection. There will be headache, fever, and meningism. Seizures are common. Focal logical deficit, which may progress rapidly to altered mental state and even coma. The combination of fever and seizure, put in your mind this sentence, that combination of fever and seizures with background of sinusitis is usually diagnostic of this lesion. Put this in your mind in order not to miss diagnosis of these patients. The investigations also, as we always say, CT scan, MRI. Despite subdural empyema is neurosurgical emergency, diagnosis is often delayed. Why? Because the collection in CT is usually so slight and frequently missed. MRI useful when the diagnosis is doubtful. I mean from this slide that MRI is better in diagnosis and better and rapider in diagnosis of subdural empyema than CT scan of the brain. You can see, for example, this CT scan of the brain. You can see that this is thin wall subdural empyema. Also, you can see this is subdural empyema at here. Sometimes may be missed if it is thinner than this and may be missed. Regarding treatment of subdural empyema, as I told you, this is neurosurgical emergency and treated by craniotomy, not by burr hole. Craniotomy. Why craniotomy? It is not like brain abscess and the pus is collected inside the cavity and I'm going to do aspiration by puncture or by through wormhole. No, this pus is surrounding the brain on the whole surface of the brain, so that I will do craniotomy and thorough drainage of the pus, followed by intravenous antibiotic and anticonvulsants, which are quite mandatory in these cases. What about the complications of subdural empyema? In fact, refractory status epilepticus can sometimes happen, or cortical vein or venous sinus thrombosis may happen in these patients. So that you can see the dangerous or the danger of this subdural empyema. Okay, by this we are finishing the subject of CNS infection in your surgical practice. Thank you for your follow me in this lecture. If any question, don't hesitate to contact me to ask me any questions. Thank you very much. Wassalamu alaikum wa rahmatullahi wa barakatuh.